Anyway, thanks everyone. Let's get this started. Hello, and thank you for the kind introduction and the opportunity to talk about some of my work. I'll be giving some background of how informatics fits in with my work as a transfusion medicine physician. I have the following conflicts of interest to disclose. None of them is specifically related to this talk. I might mention some commercial products, but their specific idiosyncrasies are relevant to the discussion, and none of this should be taken as an endorsement. The objectives are available here. So, the only way to influence people is to talk in terms of what the other person wants. The title of this talk is based off of How to Win Friends and Influence People, one of the first self-help books that was written in 1936 by Dale Carnegie. I thought that this might be a good framing device for this talk, one, because of the catchy title, and two, because while some of the advice from this book is a little dated now, I think, personally, I think that some of the lessons can be quite relevant, hence how to bin, trend, and influence people. So this is especially true because I think in the realm of clinical informatics, people mostly think about this in terms of data and systems. And of course, I love these parts of it. But I think the goal of this, the real true goal of this and medical decision making is trying to persuade people or convince people, be that staff, be that other physicians, or be that patients, to do something or behave in a certain way through these data and systems, to follow guidelines, to change behavior. And sometimes the person that we need to convince is actually ourselves for making a decision. So clinical informaticians transform healthcare by analyzing, designing, implementing, and evaluating information systems that can enhance these health outcomes. I mostly do transfusion medicine, but I'm very interested in its intersection with clinical informatics because I feel that these systems, workflow, data, that they're all part of one continuum of what my work actually is, and interconnected really deeply in the way that we work and how we think about how we practice medicine. I hope this concept will become more evident in aspects of this talk. So this brings us to the roadmap of this presentation. Today I'll be telling you about a project that we're just kind of wrapping up on right now. Basically, I'll be detailing the implementation of a clinical decision support alert. Simple stuff, right? But actually, I want to use this as another framework to zoom in and expand on some different concepts, mostly where transfusion and clinical informatics overlaps. We'll be focusing on hem-onc patients for this particular alert and for this presentation, but we did make some changes to some routine RBC thresholds or red blood cell threshold alerts as well. So the steps of this, we'll be talking about some background. Why is a system like this? Medical guidelines, why should we change? Evaluation, how is the system currently working? Implementation, what form should this take? And monitoring, did we succeed? And how is this doing? I'm going to say this and tell this story as if it was stepwise, but really a lot of these things happen in parallel, and so I'm going to gloss over some of the timelines so that it seems like it's happening in order. So first of all, I'm interested in how systems work together, and a part of understanding that is to understand where we came from. Like, why is the system like this now? So we have to understand a little bit about history here. So Seattle's claim to fame was a centralized transfusion service known as the Puget Sound Blood Center. In 2011, Harborview Medical Center was the first to splinter off of this as it opened its own hospital-based transfusion service. Then in 2016, UW Medical Center opened its own hospital-based transfusion service. I joined in 2017 from Stanford by way of Cornell, and at the time, UW had a customized instance of Cerner known as the Online Record of Clinical Activity, or ORCA. My first 3 years was basically spent re-engineering CPOE, note templates, and clinical decision support alerts for the first time. And most of this was not really optimized because of some of the newness of the service and just not having the, I think, clout to really set up things the way that would have been ideal. That's a story for another time. But basically, after many meetings and trials and tribulations, negotiation and discussion, we finally set up a system which had some semblance of working. For a year or so, until it come out that we were just going to have to switch over to Epic. So, oh joy, we have to do it all over again. But I'm being glib, but honestly, we had learned a lot of lessons from the kinds of negotiations and kinds of talks that we had had about how hem-onc surgery, how various different parts of different departments that we interacted with wanted things to be set up. So we had learned some valuable lessons, and we didn't have to reinvent the wheel. Does this mean that it was the right thing to do to set everything up the exact same way as it was before? Maybe, maybe not. But I think when people are going to go through any sort of big change or transition, then it's hard to change a lot of other things under the surface, because people get, I think, concerned that if they don't know how things are going to work in the future, then people get very concerned about that. So, okay, so we've just discussed a little bit of my work in terms of transfusion informatics, in terms of transfusion orders and the EHR. And I think it's a good time to bring up this other part of my work, which is the data that's generated from the EHR, as well as other systems like the laboratory information systems. At our institution, the data from various systems go through a program process of extraction, transformation, and loading into a data analytics warehouse, where it's subsequently processed, and you can query that in order to do analysis. And that's another big part of the, there's the front end of this, and then there's this back end, which is knowing where all of these things are in the EHR in order to do data extraction. So as Patrick already actually brought up, I got involved in this because of being a subject matter expert in transfusion and interest in data analysis as well as extraction. So just keep this in mind. We'll return to some of this in a second. So what were some of the baseline conditions that we thought might be an issue? UW practice relied on a combination of hematocrit or hemoglobin thresholds for red blood cell transfusion. And a lot of this had some historic practice that was involved in it. If you're interested in the full story, I can discuss that in the Q&A part. But there's a little bit more behind this. So in patients with hem-onc disorders had a threshold of 26% hematocrit or hemoglobin of 8.5. This does deviate from what a lot of places do in a way that we'll dive in deeper in a moment. And so this loops back into that we had set some systems in place that was based upon people's preferences at that time. So this was reliant on some sort of people aspect that we had carried this forward. And I think anyone who embarks on a journey of change within an institution will soon encounter a question of how are we currently doing? So these histograms are showing the number of RBC transfusion events that are, that are occurring in hem-onc populations. And these are binned by their pre-transfusion hematocrit or hemoglobin. So this is ostensibly the hemoglobin or hematocrit in which people decided to do a transfusion. So you can see here that actually what I find interesting about these histograms is for this is hematocrit, right? You're getting to 26% around here, right? And that's where they have the set point. So you can see that there's a very sharp inflection point over here where people are transfusing much more after you get past this point, right? You don't really see that quite so much in this hemoglobin when you're looking at the hemoglobin thresholds over here, or where that should be. And I think that this speaks to a lot of the time that patients would hit this hematocrit threshold a lot sooner than they would hit the hemoglobin threshold. So it seems like people were transfusing a lot more on hematocrit from the curvature of this graph than they were hemoglobin. Okay? Yeah. So this brings us to another quote from Dale Carnegie. A man convinced against his will is of the same opinion still. And I think about this in terms of taking an adversarial approach to trying to convince people sometimes makes people dig into what their opinions are. So I think that data and guidelines can help to kind of support change and to bring people around to what your way of seeing is. And so what part of informatics are we talking about? We're talking about change management. We're talking about, there's many different models of change management, and I think that this one from Lewin might seem very self-evident. You have this unfreezing, overcoming the existing mindset. You have change, the transition and period of confusion. You have the refreezing and recrystallizing a new mindset. But this is, so where are we right now? We're in this period of overcoming the existing mindset, trying to gain support from stakeholders, and gathering clinical champions through an educational campaign, or that's what we aim to do. And I think that some of the answers to these questions will define the scope and shape of a project, as well as give some goals for where we want to go. Okay, so the parts of unfreezing the mindset involved a campaign of literature review, as well as a presentation of data. So the 2016 AABB guidelines really provided no specific recommendations specifically on hem-onc patients, which cited concerns over bleeding and insufficient data. Therefore, there's a lot of variation that's found in transfusion practices from, in this patient population between institutions. The 2023 guidelines were published, which had added some new trials, and where they analyzed these in a meta-analysis. And the updating of the AABB guidelines served as a strong backing for proposing changes. The credibility and authority of a large established organization helps to garner support for making a compelling case for change. Full disclosure, I'm glossing over some parts of this because actually this happened a little bit, or these were published a little bit after we had started on this project, but Dr. Bogano is somebody who worked on these guidelines, so she helped to at least foster some of these at the very beginning, and these helped us with the final push. So we developed informational handouts for all the impacted staff. Additionally, we gave oral presentations to further solidify understanding for this project, and gave them the opportunity to give questions and feedback. Ideally, we wanted this to be hematologist-driven rather than to be seen as some sort of outside enforcer, especially since there were some clinicians who preferred not to make this change. So the new guidelines recommended a hemoglobin threshold of 7 for hospitalized adult patients who are hemodynamically stable, 8 for patients who are undergoing orthopedic surgery or with pre-existing cardiovascular disease, and 7 for hospitalized adult patients with hem-onc disorders, although this was conditional and with some low certainty of evidence. So because of this, we needed to, I think also, in terms of operationalizing this, give a lot of leeway to people to make changes as they needed. So the consensus among the hematologists was reached that we could have this more restrictive hemoglobin threshold, and as long as they had not had severe risk of bleeding, or that they were not undergoing stem cell transplant or having a hemoglobinopathy. So basically, the implementation of this alert was going to have both this threshold being implemented, and we wanted to give this something that could give it a little bit of more of a push or give it a little bit of teeth. So we implemented what you would call a clinical decision support alert, which is also branded as best practice alert or our practice alert in EPIC. Okay, so next quote, knowledge isn't power until it's applied. And so let's return to the application of the guidelines. As you may have surmised, the baseline system and where we want to go leads naturally into what our primary goal was for this project, which was to implement a restrictive strategy for patients with hem-onc disorders, and as well as to standardize the hemoglobin as a goal rather than hematocrit. So clinical decision support. Clinical decision support provides clinicians, staff, patients, or other individuals with knowledge or person-specific information that's intelligently filtered or presented at appropriate times in order to enhance health and healthcare, according to healthit.gov. Most people associate clinical decision support with interruptive alerts, and clinical decision support really refers to so much more. That includes context-sensitive display of information, recommendations or guidelines that are integrated into the workflow, or reminders for preventative care, or links to resources. Basically, some of the work with patient blood management and clinical decision support alerts had started with this guy, Professor Dr. Goodnow from Stanford, who pioneered in this area. And he showed a 30% reduction in RBC utilization when implementing alerts at his institution. Now, other people have found more modest improvements of maybe 10 or 15%. And I think that depends on how it's actually implemented. Okay, so in the EHR, there were some foundational, out-of-the-box best practice alerts, or alerts which we found to have some useful features which we wanted to incorporate. That is the display of text of the guidelines being cited, so over here. The ability of the user to remove or cancel the order by default, and requiring some acknowledgement reason. So note that this can be set to optional. Okay. And you might say, that's interesting. How did we find out that there were some foundational alerts? You see, we had actually just gone through an Epic kind of rollout. And we had never actually asked for some specific alerts to be turned on. They were just kind of turned on by default. And it's kind of funny, I don't think that our builders or analysts were even aware that these were just firing. And we didn't really have access to really see that these were firing until we had access to some of the other systems through Slicer Dicer, as well as the Physician Builder program, once that got going. They're not named something that's very descriptive. They're named kind of like blood revenue, all patients, including CV problems. It's not something that you would think is something that's important. I think the other curious thing that we found out was when we started to analyze when are alerts firing. So these are when alerts are firing and what hemoglobin values that they're firing at. So apparently, these are built in where they only fire in this narrow window, or this particular alert only fires in a narrow range of 7 to 8 grams per deciliter. They're just actually built wrong at the outset. So they shouldn't be firing. They should be firing all along this axis, and we just found out, oh, they've just been firing for this very narrow band. And when we actually had got the opportunity to look under the hood for how these are built, yes, that's exactly how they're built, to fire greater than 7 and less than or equal to 8. And that's not really how you would want these to fire. So just something I think that this is a good lesson learned, that really a lot of the time when you're looking at metrics, that's something where it can actually help you to identify that some things are not working the way that you intended, even if you ask them to be built in a specific way. So if you must make a mistake, make a new one each time. And yeah, we really have to, I think, make sure that our internal, or the data that we look at, whether or not that actually jives or that actually matches up with how you think that this system should be functioning. So now we're talking about, let's pivot a little bit and talk about, okay, actually implementing this. So we have the structure of what the alert that we want, or at least a baseline. And then now this other part. So we have these guidelines. How do we codify these guidelines? We have to turn these guidelines into something that actually is something that logically works within the system, right? So we're taking medical transfusion guidelines and turning them into specifications for how we want the system to be built. Based upon the guidelines, we want 3 different mutually exclusive practice alerts, that one for a generally stable patient, one for a hem-onc patients, and then another one for cardiovascular disease. If somebody has a cardiovascular risk, then that one is going to take precedence over the other ones. And they shouldn't fire, and they should fire mutually exclusively so that they're not firing all at once, because that can happen. That's another story. But also, there's other parts to this. We want to exclude bone marrow transplant patients. We want to exclude patients with sickle cell disease. We want to have manual overrides if our automatic detection misses. We want to have some escape clauses. Basically, when we start to do this, our hematologists start to ask for other ways that they could customize, ways that they could not have these displayed to them. If you've ever heard that story, if you give a mouse a cookie, well, if you start on any project, that's called scope creep. But I think that it's important to say that we wanted to address people's concerns over whether or not they're making some sort of change where possibly they are going to see less autonomy in terms of their practice, and people want to be able to have a lot more control over this. So we made some escape clauses so that these would not be displayed or be suppressed if people had massive bleeding or trauma, if they were undergoing imminent discharge, if there was severe thrombocytopenia, or there was bone marrow transplant in the last 90 days. So that was just in case we missed bone marrow transplant, et cetera. Okay. And one of the ways that we start to build this is, and one thing that I think was very helpful for this was our physician builder program. So let's talk about physician builder programs for a second, just as a paradigm and not necessarily limited to this context. These are basically programs where physicians who are interested in informatics, quality improvement, can gain some access to the inner workings of the system or the platform, in this case, the EHR. This has some advantages. One is the ability to analyze the build, right? We were able to discover that the system wasn't functioning as we intended through the fact that we were able to actually analyze how things were put together, because sometimes people will put things together and then they'll tell you that that's the way that it works, and it's not how it actually works. And having increased awareness of the system's capabilities, so you can know how things are supposed to be put together and be able to direct somebody to put them together in a better way. And also locate where data is, like that there's some sort of button that does something, and then so if you know that that button exists, then you can go and look for the outcome of that button in the data later on. And one of the things that we did for this, or that I got very involved in for this, was the ability to prototype a build. So I was able to kind of like put together what this should look like. And especially this can be true for complex medical logic. So you have analysts where sometimes if you're explaining this to an analyst, maybe if there's a lot of complex logic in terms of the mutual exclusions, then it's a lot easier to maybe just do it yourself and just kind of build it, rather than going through a lot of back and forth with that particular division of people. Okay, so this is basically the workflow diagram for the hem-onc alert. It fires inpatient. So this is some of the logic. It starts with the provider order, and then it fires inpatient based upon hem-onc locations. It has some exclusions where if it finds that there's some coronary artery disease, that it will not fire. And then it has some other buttons or other parts of this logic where if it finds that the patient is undergoing transplant or has transplant kind of locations or divisions, departments that they're associated with, then it will not fire. And also if they have hemoglobinopathies. And then and then the part where it looks for what the hemoglobin value was in the last 24 hours, right? So once it fires, it will display the guidelines, and it will also display the hemoglobin values. It will allow people to remove the orders, and it will also have a bunch of these acknowledgement reasons which have to do with the specifications that we just talked about. So the outcomes of these are that they will suppress the alert. There's also one thing that goes into this is that some of these will allow you to go to different other workflows. So if you were to hit this, if somebody knew that somebody had coronary artery disease or cardiovascular risk, then they could hit this button for the severe coronary artery disease, and then that would be something where if you were in where some of these other alerts basically look for a flag that's set, and if that flag is set, then it will go to that swim lane in a sense. So I think that that's one of the special features of this. And then we also made a couple of other ones for specifically for the general kind of hemoglobin alert, and as well as for the coronary artery disease alert. But the structure of these are mostly similar. So it's just that this one has to take precedence over other things if coronary artery disease or cardiovascular disease is found. So okay, in terms of learning our lessons and in terms of knowing that the system is built as intended, we also came up with a validation plan, which is not something that I think analysts normally do a lot. But basically what I did to make this a lot simpler for them is that I came up with about, I think, 40 different cases of different types of patients of different types of test patients and what should happen in each of those cases. So you have your regular patient who doesn't have any cardiovascular disease, and then they have a certain hemoglobin value. So what is supposed to happen? Which best practice or which alert is supposed to fire? And then if they have cardiovascular disease, if they don't, et cetera. So all of the different permutations and all of what you should see in each of those cases, which alert should fire, and so only one alert should fire for these different cases. So this is kind of known as A/B testing, and it's critical for this because that we did this because one, if we were turning this on for a lot of patients all at once, then we have to make sure that everything's kind of in working order before this. And based upon this, we did find some things that we needed to switch around and change. Okay, so so now that we've built this, right, we've kind of activated this, we've let it out in the wild. So what's the next step? We have to basically do some metrics to figure out how did we do. So let's take a closer look at some of the data pre and post implementation to tell that. So what are the quality metrics that we would be interested in? Some of them could be just general, like how often is this alert firing, just in general. What's people's course of action when they're seeing the alert? I'm going to mostly focus on these parts. So these kind of outcomes. So whether or not there was a change in RBC utilization after this, as well as perhaps patient outcomes. So people were interested in patient outcomes. Was there a change in the length of stay in terms of the hemoglobin and hematocrit before and after transfusion? If people fell to very low or very low hemoglobin or hematocrit levels after transfusion, whether or not there's bleeding, transfusion reactions to RBCs, and number of fever days. So some notes about this is that in terms of what sorts of assumptions that we made. One is that we were looking at age of admission greater than or equal to 18 years old. We were looking at HEMONC services, so HEMONC A, B, C, D, And so those services in particular. And we were looking at a certain range of dates, pre-implementation and post-implementation. One thing that we did do is divide by patient days. So this would normalize by the patient volume. Even if you're looking at the same time frame, you might have different patient volumes within that time. So how would we normalize for that? One is that we normalize by the number of days that patients were in the hospital, because that speaks to the volume. And then we excluded any patients where the encounter was in between the transition, just because that can get kind of wonky in terms of what people are following in terms of their thresholds. And we excluded, of course, patients with hemoglobinopathies and bone marrow transplant. Yeah. So focusing on the hemonc alert over time, there was an initial spike in the alert firing when the initial change was implemented. So, and this quickly stabilized to about 20 to 30 alerts per week. And then there was another spike over here. This might be a little small, but that's in June, July. So you can kind of imagine that was when there's new kind of trainees and residents coming in, and then followed by another plateau after that. So I think that this kind of speaks to who was being displayed the alerts. So when you actually look at this, the majority of these alerts are actually displayed to trainees. And then I'd like to bring your attention to the kind of cancellation rate. So there was about 16% cancellation that they would either hit this remove or cancel button when this alert is displayed to somebody. So you can say that, okay, well, maybe they are canceling these alerts, but does this actually completely describe user behavioral change? So these are some of the histograms from before. You may have recognized that this is the pre-implementation hematocrit that's before transfusion. So this is a pre-implementation hematocrit threshold. And then you can see over here that this has shifted over to the left. Post-implementation, 21% hematocrit is no longer supposed to be a specific target. But you can see that it has shifted over towards this 21% hematocrit, right? And then you can also see that it doesn't really have that inflection point really, or that sharp inflection point really. So I thought that that's interesting. So let's look at hemoglobin. So hemoglobin is supposed to be the target now. And you can see that, okay, there's been a shift over to the left, and the majority of these transfusions that were happening at this higher level are likely no longer happening before. When we look at the red blood cell transfusions per patient day over here, there's about a 30% reduction over here, and this was with a significant p-value. Based upon this, I said 30%, I meant 25%. So the transfusions per patient day were reduced by about 25% pre and post implementation, and we estimate that about 1,300 less transfusions happened in 12 months of implementation. If you multiply, do a simulation where you're multiplying by the old rate of transfusion versus the number of patient days that we were counting. Okay, so one of the things that people were concerned about is, based upon the fact that you have this hypothetical patient. Hypothetical patient number one is being held at this 8.5 threshold, and then at some point you're testing them each day to decide whether or not you're going to transfuse. Are they dropping to low levels? If you're holding them at a higher level, people were concerned that, okay, well, they're not dropping that low because they're being held at this higher level. So how low do they go? How low do these patients drop before you kind of find that and then then transfuse them and hopefully get them back up to this threshold, right? So we were looking at the number of days where patients would fall less than 6.5, or less than 6.0, or less than 5.0 in terms of their hemoglobin. Are they falling to very low hemoglobin levels or dangerously low hemoglobin levels before we catch that and transfuse them back up, given that they're closer to those low levels, right? And we found that, okay, well, people are falling to 6.5, and this was significant. So about 40% increase of getting to 6.5, and this was statistically significant, but they weren't falling to less than 6.0 in terms of their nadirs, or the number of days where they were falling to those low levels. Okay, I think that it's questionable. Like, how is this bad that they're reaching this more often? Is this clinically significant? I mean, it's statistically significant that this is happening, but I think at some levels when people do I would argue that at some level when people do their randomized control trials where they're holding patients to a strict 7.0 threshold, at some level, people are probably dropping below that level before they transfuse them back up. And in those cases, no harm has really been found. So I would say that this would probably be akin to that. But we can discuss further if people want to talk about that. Okay, so what about these other metrics? So I have here kind of indicated whether or not these were desirable outcomes or not, and then some, and I have some caveats for some of these. So length of patient stay, platelet transfusion as a stand-in for bleeding, as well as number of positive blood cultures, percent of readmissions within 48 hours, or falls per patient day had no statistical difference between them. Obviously, we already talked about the RBC transfusion per patient day. The transfusion reactions per patient day went down. That kind of tracks with the fact that less transfusions are happening, right? One thing that we did find that was kind of weird was that the number of fever days per patient day, so that's the number of days where patients reached a fever, that's agnostic to whether or not this was before or after they had a transfusion, okay? But that actually went up, but we did the same sorts of statistics for hospital-wide, and we found that for whatever reason that it's gone up hospital-wide as well. I don't know if it's some sort of systematic way that people are measuring it, or if there was some sort of COVID spike during this time. I don't have a great explanation for it, but that was one of the other things where this just tracks with how the hospital is doing. Okay, so basically, just to kind of talk about this in general, we've implemented a new clinical decision support alert, and we've seen that based upon these metrics that we have not, that patient outcomes are as good or perhaps or as good as they were before, and also we've been able to transfuse less overall, right? So how to bend, trend, and influence people. So I really use this as kind of a framing device, but I think that I could have talked about any particular project. And really, I just wanted to just talk about that clinical informatics and transfusion issues revolve around data, systems, and people, how to bend, trend, and influence people. So transfusion informatics analytics, or analysis of workflows, I think is important in streamlining EHR build and checking that things are built as they are intended. People gain confidence in the system through system change, through data. And then data access and transparency is, I think, also critical to understand how our systems are put together and whether or not they're put together in the way that they're intended. And I think that if we recognize how these things influence each other. So people influence systems and data and systems influence how people work and how people think. So in a way, all of these things interact and influence each other. So by influencing these two things, you can influence this other thing. Just to, I think, bring it all home. And to a certain extent, just to reiterate what I said before, I think that based upon the fact that all of these things play together, I feel like that, in my work, that all of these things are all part of one continuum of how my clinical analysis, or how my data analysis works with the kind of clinical things that I do, as well as the systems things that I do in terms of quality improvement. So I really kind of think of these things as all kind of interconnected in terms of my job. So last part of this, people rarely succeed unless they have fun in what they're doing. Some parts of this can be frustrating. The people part especially. But I really like it, and I try to have fun with it. And at least with the data and technology part of this. Last Carnegie quote here. So talk to someone about themselves, and they'll listen for hours. And I certainly have been talking a lot. So I will take any questions and continue to talk if people have questions. Okay.
Let's start on that side with, I guess, no. Hamilton, that was great. A comment and a question. The comment is that we don't have outcomes for CDS very often, so I just want to say that this is really, really great. Super to see and unusual. The question is, so I'm aware that you develop a lot of expertise in SQL queries, in our Epic data warehouse, Clarity, in the native Epic tools for performing various analyses that don't require like very specialized SQL knowledge have developed over time. I'm wondering if you have a sense for whether the investigation that you did could be done using Epic, sort of native Epic tools.
So, yeah. So the question is whether or not this sort of data analysis can be done with native Epic tools. I think that you'd have to use Cogito to do that. And that actually, if you're working with Cogito, then at that point you are basically doing SQL queries at that point in time. One of the things is that some things like Slicer Dicer or like their kind of out of the box stuff doesn't really have anything that has to do with doesn't have any way to work with how many transfusions happen, right? They don't actually, there's not actually a thing that's some sort of variable that you can work with. And I don't think that it handles it all that well. And partially that's probably because they don't have a blood bank module, which, they keep saying that they're going to build one. But, until I actually see it, then, it's not actually there, and it's not actually going to be helpful. So in order to do these, I really had to kind of go into the back end and to actually grab these, because they don't really have a way to work with transfusions very well. Yep.
So you'd imagine that the actual end goal of these best practice advisories is to change the culture so that they don't actually need to fire anymore. Do you have a sense of sort of the lifespan of this, like BPA or BPA sort of overall? Like, is there a threshold of if it's only firing twice a week, like, oh, we might as well get rid of it so it doesn't end up sort of being a Frankenstein BPA that lasts for forever?
So the question or comment is that whether or not there's a sunset life to the best practice alert or to a clinical decision support alert. And I think the thing is that there's always turnover, or I guess I'd argue that there's always turnover. There's always people who are coming in, and for the most part, a lot of these are being shown to kind of trainees, and you see a lot of a spike of these happening. So I think for the most part, I'd say, Yeah, I think that these things kind of last forever, just because, or like, yeah, basically, there's always going to be new people who are coming in where maybe this reminder is going to be helpful. Like, and that's one reason why I think that there's these, where we've put in these suppression mechanisms. So people have the ability to suppress these for good reason. And I think if you're talking about kind of vigilance in terms of lab utilization, when is everyone going to order labs perfectly? I think I'd put out as a question back to you.
Just one comment related to that. We've had good collaboration. So Noah, myself, and some of the other informaticists in the non-transfusion domain have worked very closely with Andrew White and our clinical decision support team, and we've actually I think we've actually literally removed more unnecessary alerts over the past 2 years than we've actually added alerts. And so I think part of the goal is let's get rid of the ones that are not as useful. Transfusion, I think the transfusion alerts are much more impactful than some of the other alerts, and then that way we can decrease some of that noise so that the signal noise ratio of the other alerts that are meaningful will be higher.
Yeah, I think one other thing that I would maybe point out is, or that I didn't quite talk about in terms of this, is that you see here that I think that this peak is not really as prominent. And one reason why I think that it's not really that prominent is because I think that we've given a lot of leeway for people to transfuse if they think that somebody requires a different threshold. So, so you see that it does increase here by a little bit, but this, what you might call noise or people transfusing when people are above that threshold, is probably some amount of that leeway that you would see, or that we've given to providers, I would argue.
Go back, if you leave that slide,
Okay.
I just had a quick question about this one. You didn't mention this, I don't think, but this, the pre-implementation hematocrit for transfusion, it looks like it's bimodal. Is that just because there's different transfusion thresholds for different clinical scenarios?
I think that yeah, I think that to a certain extent there might be some patients who might have solid organ kind of, because this is hem-onc, and then so there might be bimodal, but it's difficult to really tease that out. I kind of thought that before. I have a slide where I have maybe being like, oh, maybe this peak is being unearthed by this stuff going away. Possibly, but so I will give you that's I think that's a possibility. Yep.
Hamilton's great work, great talk, but precisely on this point, it is counterintuitive that having a lower hematocrit, still allows you to get out of the hospital in the same time, to do as well clinically. Mm-hmm. We saw this in the TRIC trial 25 years ago, that giving 2 units of blood didn't allow you to get off the ventilator any faster. But to be able to do it for the whole hospital, and show that dropping your hematocrit, that we're not keeping you in bed longer because, you're just not strong enough to do what needs to be done. That this is important precisely because it's counterintuitive.
Thank you. Should I repeat that, or no? That's I'll just say thank you to that.
Mark comment, but really cool work. I think there's lots of other settings outside of transfusion where you have these very strong parameter thresholds that are called treatment. I think the code base you've set up to analyze some of those effects, etc., could probably be applied more broadly across other settings. They're just interesting to look at those emergent threshold effects on treatment decisions, whether they're guideline involved or when they're not. Are there situations where people are taking more leeway in terms of treatment decision making that we realize, whether they should or shouldn't, etc. Just interesting. I wonder if there's other uses outside of this.
I think there definitely are other uses. We're kind of, so this was, just to repeat this is a comment on whether or not there's other uses of this. kinds of analysis. And I think definitely one of the things that, or one of the, I think the interesting analyses is this kind of like pre-event kind of decision-making process. And I think that's something that we can definitely apply to something like platelets or to something like cryo. That's something that we can look at, not in this particular population, but we've changed some of the other, or since we started to implement this clinical decision support alert for cardiovascular disease, actually, because it wasn't firing right before for various different reasons. But because now, actually, we saw that there's a little bit of an increase hospital-wide in some patients being transfused at maybe some higher levels, probably because that wasn't functioning before. But that's something that's would be intended, and that's something where we could probably look at either the ICUs or various different populations to see whether or not how those things, whether or not also if their outcomes are become any different, because that's another thing that we changed, but we weren't focusing on that particular thing. Yep.
And just the cost savings of all of this, down the system. A unit of blood costs a red cell is about $250 to the system, but to actually give it, we pay another, almost $1,000 just, for the time that the nurses are spending. And so not only have you saved, $1.33 million to the system, you've saved 260 hours of nursing, 2,600 hours of nursing time, which is about the equivalent of 2 nurses.
The comment was on the cost savings. Yeah, we did look at the cost savings, but sometimes it's not really political to just, because then you become kind of like a money grubbing, because it's not supposed to be about that. But we did look at that, and so there's a significant amount in there. I just kind of had that in there and took it out.
I mean, I think the nursing time is key, right? So you can save a lot of nursing time that's critical to for the hospital.
Yeah, free up the nursing time for higher yield patient care activities. I mean, I think, Hamilton, I'm struck thinking about this, and I've been struggling for a way to phrase this question, but I think John's point a minute ago was right on. The differences you've shown pre and post implementation are very small. And I wonder, it sounds like maybe there's no resistance, but if you were sort of had naysayers who were still curious about risk of patient harm, things like length of stay, if you have a way to track sort of bleeding events, I think you probably see that in the transfusion data, or other patient outcomes other than fever. I mean, those might be other things to look at. I wonder if you've already looked at that. I assume there'll be no difference pre and post.
Yeah, I think one of the things, or one of the kind of things that people can bring up is that these are kind of proxy values for other things. They're trying to, because you're trying to look at this on a large scale. So people were concerned about bleeding because that was one reason why the set point was what it was before. Don't want to get into that too much, but that was one of the reasons why the set point was where it was before. And so people were concerned about bleeding, but actually one of the things that's actually very difficult is people don't know, it's very hard to determine whether or not a patient is actually bleeding, at least on a large scale, because it's not very consistently documented. And that's actually one of the huge problems, is to be able to say whether or not there's greater or less bleeding in a patient. So we're trying to have all of these proxy values in order to kind of infer whether or not that's happening. And that can be kind of difficult to do, and that's one reason why I think people still have concerns over that. And there might be some, and given there might be some subpopulations where that's needed, and that's one reason why there's a lot of leeway in there. So, that's a lot of, kind of like talking around what you're saying, but that definitely is a concern that people have, and so we've tried to, I think, address that as much as possible.
I thought your the portion of people who slipped to below the threshold for transfusion and a restrictive scheme addressed that. It seems like length of stay and we're 30 to 60 minutes are probably too strong,
Yeah,
but might be helpful to show and know to kind of all the.
sure. Yeah, and in all of these, we did power calculations to see that, and yeah, it took us that we had to do 1 year of data in order to have the amount of power for 80% for some of these. Yep.
Hey, Dr. Sang, for the transfusion events, were these for all types of blood products, or are they only for red blood cells?
This is only for red blood cells because this is just for RBC thresholds in hemoglobin. But there's definitely room for this to be done for other different blood products. I think it's just, figuring out which parameters are the right ones and what are the right escape clauses for people and under those circumstances, and doing something before and after that would be necessary for something like that.
And to follow up on that, did you look into data to see if there were changes in other blood product administration from this one just for red blood cell?
We tried to look at whether or not there was differences in platelet transfusion, because that would be, in this particular population, something that we thought might be an indicator. Oh yeah, the question was whether or not we looked at other different products, and I already answered it. So, okay.
All right. If there's no further questions, thanks. Let's thank Dr. Hamilton.
Okay. Thank you.